afternoon, and welcome to Keys to Effective IT Capacity Management, aligning resources, transparency, and communication to meet demand. A health system CIO production. Just a little housekeeping before we get started. My name's Anthony Guerra. I'm the founder and editor in chief of Health System CIO, and I'll be your moderator today. We're looking forward to your participation. You could send in your questions or comments at any time in the Q&A box, and we'll take them later in the program. Just so you see how we're going to spend our time today, first we're going to go about 35 to 40 minutes with our main panel discussion featuring Naomi Lenane, CIO and VP of Information Services with Dana-Farber Cancer Institute, Mohammed Siddiqui, Chief Digital and Information Officer with Reed Health, and Rich Temple, former VP and CIO with Deborah Heart and Lung Center. So with that, let's jump right in. Naomi, let's start with you. Can you give us an overview of your organization and role?
Sure. Thanks, Anthony. Welcome, everyone. Happy to be here. Naomi Lenane, and I am with Dana-Farber. As Anthony said, we are a hospital and research organization in Boston and surrounding areas, and our focus is oncology and cancer. And our mission is to find the cure for cancer, but also treatment and sort of end the burden of cancer for patients and families and caregivers. I'm the CIO and SVP of Information Services. I'm responsible for all of the hospital and operational systems, network, hardware, sort of everything we need to run the hospital. I have a colleague who's responsible for the majority of the research organization, but I am responsible for, the foundational systems like data center and network and hardware, as well as our EHR, all of our clinical and operational systems, ERP, everything to run our hospital, including everything from sort of welcome center all the way through to philanthropy. So we have a pretty broad scope within my organization, and it's great to be here today. So thanks.
Oh, you're welcome, and sorry I didn't have your S in your VP,
Oh,
but
that's
I'll get
okay.
that fixed.
No
All right.
worries.
No, it's good. It's important. All right, Mohammed.
Sure. Oh, thanks, Anthony. Thanks for having me on this panel today. I mean, I have been looking forward for this a crucial conversation topic about one of the healthcare most critical challenge that most of the CIOs and other technology leaders are facing today. I serve as the Chief Information Officer at Reed Health, where I led technology, strategy, operations, and digital transformation across our health system. We are 274 bed hospital serving around close to 400,000 people across East Central Indiana and West Central Ohio. 8 different counties in a community that depend on us for everything from an emergency care to the complex surgical procedures. My role is span around the full spectrum of healthcare IT, electronic health record. We have Epic, clinical systems, cybersecurity, data analytics, infrastructures, and artificial intelligence, of course, and automation out there as well. But what really drives me in the intersection of technology and patient care, ensuring that every system we implement, every process we optimize, make it easier for our clinicians and easier for our patients to be able to use that feature that we implemented there. I have spent 27 years in healthcare watching this industry transform from a paper chart to today interconnected digital system. Oh, let me go back. Not interconnected digital, but more of the artificial intelligence ecosystem. What I have learned is that technology is only useful as long as you be able to provide the reliability and be able to get the adoption better. And that's the motto I have for my team at the Reed Health today. Thanks for having me, Anthony.
Oh, great, Mohammed. Excellent. Looking forward to talking. Rich.
Good morning, good afternoon, everybody. Anthony, thank you so much for having me. I'm delighted to be part of this august crew that'll be discussing this vital topic. I am the recently retired Vice President and Chief Information Officer for the Deborah Heart and Lung Center in Browns Mills, New Jersey. We're in the wilds of New Jersey. We're in the part of New Jersey that doesn't look like what your mind's eye pictures New Jersey looking like. It's very bucolic and green and very rural, and really a nice place to be. We're a small cardiovascular specialty hospital. We're on Meditech, so we're different in that respect. Being a smaller hospital, it's worked well for us. And I oversee most things that plug into our network, which are at a hospital, really most things. And I've always been driven by the passion of finding ways of using technology to improve patients' lives, to improve our stakeholders' lives, to improve anyone who touches our system. I want to be able to make their lives easier through technology. I want to be able to automate things where appropriate. I want to be able to just make sure workflows are as optimized as they possibly can, and technology is a vital piece of being able to do that. One of the things that's unique about Deborah Heart and Lung Center is that we're one of 3 hospitals systems in the country that don't balance bill our patients. Right? St. Jude's or Shriners, and then there's us. So that's really woven into the DNA of everybody who works at Deborah, that, we do this. It's really core to our mission, and it's something we're all very proud of. The good news is that we recognize every day how impactful what we're doing is for some very, very vulnerable people. And the bad news is that we never have any money because we don't have that vital revenue stream. But at the end of the day, it's something that we feel very strongly about. It's been core to our mission for 100 years. And we want to continue to do that. So again, I'm delighted to be here. I'm delighted to discuss this. And thank you so much for having me.
Well, you got it, my friend. All right, excellent. Naomi, we're going to start with you. And I hope this question doesn't sound silly, but I sort of want to just get into a little bit of the dynamics. We all understand the concept of demand exceeding supply, but when it comes to an IT shop in a health system, just maybe take me through a little bit of it and how it happens and why it happens and why it's a challenge.
Sure, happy to start. I think, you know, we probably have the same issue that other foundational departments like HR or sort of enabling departments have, that we are the one place that everyone needs to go. So, I mean, demand is going to exceed the resources when we think about the fact that we're, trying to support every, if you're at a general hospital, you're trying to support every specialty. At a cancer hospital, I'm trying to support every, specialty or specific disease center within, my organization. But sort of everyone is coming to you, whether it's nursing or physicians or the pharmacy or, building maintenance systems might be part of your scope. Philanthropy is part of my scope. So you have every area of the hospital is looking to the one department to solve their needs.
Mm-hmm.
And so I think that's really the core of how, all of these folks, and I know we're going to talk about sort of how do you fix this problem later, but if you really think about it, one of the core issues, and I know it happens with HR or security or like other departments in the hospital where everyone is relying on this one group of people to sort of solve or be involved in or provide resources for, the technology. In our world, it's like we're trying to solve technology problems across a whole enterprise, and there's only so much time in a day, only so much budget, only so many physical people to do the work. So from our perspective, or from my perspective, we try to enable as much as possible, but it really is clear that, the need coming in is coming from so many different places. We also have the fact that we're trying to now maintain everything we've already brought in. So, if you think of some of where input comes from, a nursing leader, it comes up with an idea, we implement that. We also now have to own it forever, maintain it, do upgrades, so it increases the support need. So each demand really then increases some semblance of how do we support or maintain this, yet they're moving on to the next idea. So I think it's not just that, you're supporting everyone. It's that even the folks who you're taking input from, they don't see sort of the foundational support or maintenance needs that increase with each, new idea. So, that to me sort of the probably two basic ways you can think about how demand will exceed your resources, sort of period. It's going to happen everywhere. I think Muhammad would say, we all have the same issues, and that's going to happen everywhere. And there's two key reasons, and others might have more.
Yeah, that's great stuff, and we'll dig into that a little more. So thank you, Naomi. Mohammed, what are your thoughts?
Yeah, no, I mean, you spot on, to be honest with you. Here's what I tell my team every day. If the technology we are building doesn't really solve a problem, I'll take an example of the nurse. If the nurse shift easier using a technology or a physician decision making more informed, we are building the wrong thing, right? This that philosophy actually shapes everything we do, especially how we manage the constant demand or tension between the unlimited demand and the finite resources that we all have nowadays. I mean, picture this. I'll give you an example. Just yesterday, you walked in, and you have a three department head sitting and knocking the door and sitting into your office. Emergency department wants to need a new triage system or whatever the system they want to reduce the wait time. Nursing leadership wants to do XYZ, and a provider wants to do something completely different, right? and and the irony is there is you're going to be using and utilizing the same resources. How are you going to balance the demand? That is a biggest problem today. So the demands come from everywhere. Clinical departments see technology solutions that could transform their workflow. Quality department teams see that, hey, listen, can I be able to get a better analytics that be able to share with the quality steering committee or the board they report up to, right? But our resources, especially skilled people, are very much understanding both technology and clinical workflows are very, very limited nowadays, right? I mean, we're not really getting any additional FTE. Like Naomi said, I mean, we not only have to implement, we also have to keep the lights on. So, and some of the system that we have, we just cannot just hire our resources on a street. I mean, that does require years of experience for understanding the clinical needs and wards and understanding the system as well. So I'm with you on this as well, Naomi. I mean, we do not have unlimited resources, but demands up keep coming and knocking the doors.
Excellent. Perfect, Mohammed. Thank you.
Yeah.
Rich, what are your thoughts?
I think Naomi and Mohammed really nailed a lot of the essence of the challenges that we're experiencing right now. In my world, or what was until very recently my world, our IT department is actually smaller today than it was a few years ago. I mean, the budgetary realities that we're dealing with being what they are, we have fewer people supporting even more systems. And in this day and age, with AI booming and with cybersecurity being an ever-present concern and with interoperability and a whole multitude of other things that perhaps weren't quite as top of mind a few years ago, there are demands that are coming from all sides, and those demands take on many forms. And the challenge really is to balance that. We do have to do more with less. I know that sounds like a buzzword almost to say that, but we do. And we have to identify where we may have to look outside in order to accommodate a particular need in the consulting realm or something like that. We also want to look and see if there are areas where certain departments might be able to be more directly involved in the care and feeding of their system in a way that doesn't compromise the integrity of the system. So a lot of challenges. We truly are doing more with less, and I see these needs growing exponentially as these new technologies, AI in particular pops into mind, are really gaining a foothold and are things that we have to do in order to continue to grow our business.
Excellent. Perfect. All right,
Hey,
let's go ahead.
Can
What do
I
you want?
can I just
Yeah.
add on a rich point is I think the another irony that I see the most successful, which I notice it in my shop as well, if we are successful able to demonstrate the IT value, the more demand we create, successfully create more and more demand. So for example, if IT show a lot more agility and be able to showcase more ROI, our demand become increase and higher and higher. So I mean, it's very very hard to say no sometime. The question the question become, how do you say not now legitimately patient request or coming from a doctor or coming from a nurse or your revenue cycle team. That's where the strategic demand management become a very very critical, and I think we all have some sort of that system in place today, but I think we all struggle this every single day.
Well, let's just go right there. Well, let's just go right there, Mohammed. How do you say no? And this is where we've got all questions where we get into this, but let's jump into it here. The idea here, I think the core idea here is transparency, right? I mean, what else do you do beside manage your resources well, right? So you're going to optimize the use of your resources. You're going to ask for as much as you can get. You're going to try and get your budget increased. You're going to use good business practices to do that. But so you're going to get as much resources as you can from the organization, and then you're going to deploy those resources in the most efficient way possible to address the right projects, and that's where we have governance come in. So you're going to dovetail with the strategic direction of the organization that's put out there by the CEO. So they say, here are the things we want to be great at and we want to focus at. So you say, okay, I'm going to use my IT resources to support those pillars. I'm going to select specific projects. Either we initiate them or the users request them. There's going to be a combination of those things meeting in the middle. So I'm going to get as much resources as I can. I'm going to deploy them in the right way, and then I'm going to be transparent with everyone about what's going on. So you're upset about why this is number 6 on the list. Here's why. Here's what I have. Here's what we're doing. There you go. I mean, in a fundamental sense, is that kind of what we're trying to do here, Mohammed?
Absolutely, and I think you are spot on there. I think we all learned the hard way that you can manage demand, right, by just saying no, right? You have to shape it, you have to prioritize it, and you turn into strategic opportunity. I mean, our approach at Reed Health center on what I call a transparent partnership, and you touch on this, Anthony, as well. Instead of ITs being the department that kills good idea, we are not anti-innovation, right? What we are anti-fragmentation. I use this quote at my meetings with our C-suite as well. We become the team that helps the stakeholder to understand the art of possible, right? Within the real world constraint and what is available today at the organization today that we already have heavily invested funds there as well. So what we do at Reed Health, we characterize every request into 4 different buckets. So we have regulatory and compliance, we have a risk mitigation, we have an operational maintenance, we have a strategic initiative and innovative opportunity, right? Of course, compliance get automatically, what I would say the top number 1, and a cybersecurity probably go in a top. Your maintenance, which is keep the lights on, take your 60 to 70% of your capacity, right? To keep the lights on. So your strategic initiative compete based on the organization impact, right? The innovation get pilot opportunity where you're pulling maybe 1 or 2 resources when capacity allow.
Mm.
So we just don't evaluate the request, right? We also need to educate the requester. So we hold at Reed Health the monthly IT office hours where department leaders can discuss their challenges before they become formal requests often. And we often discuss some of those challenges are maybe a training issue. They don't know how to utilize the function that we have implemented, right? So my take on the demand management, the best demand management system uh, isn't managing the demand, to be honest with you, right? It's creating the informed demand, right? When stakeholder understand what possible and how complex and what's coming, they become partner in prioritization instead of competitor for the resources. I'll give you an example. At Reed Health, we launched 2 years ago Epic Refuel project, very successful project. We implemented agile methodology where we put our stakeholders on a driving seat as a scrum master, help them pick what do we need to work first. This is your capacity, this is your backlog item, this is your storyboard. You decide what item we should work on. And guess what? We were very successful. We hit In less than 8 months, gold star 9, less than 5 months, we hit gold star 9. We are 2 years back to back in gold star 10 with the same demand management process we have among the EHR systems.
Very good, Naomi. What are your thoughts here?
Yeah, I think it will really depend on the culture too of the organization. So you need to know or learn sort of how governance works at your organization. So we don't use words like prioritize, but we focus on timing. So so it isn't sort of not now or no, it's when. Like here's when we can do that. So you're not saying not no, you're not saying yes, but you're saying when something can happen. We also do that for the most part, sort of within like not even in the four buckets Muhammad talked about, but in those types of buckets, but within an area. So like business applications decides what's happening in business applications and when that is happening, versus Epic is looking at Epic, right? So we don't, unless there's things that are Windows 11 or other hardware they go across, we're not necessarily, we're not letting doctors wait behind, finance, right? We're definitely trying to keep everything close to the end user, which I think helps because we're not trying to make people think about the whole organization. I worry about the whole enterprise. They don't care. They care about their area, right? So how do you help them think about their area and what's happening within their scope? And how does, there may be some big projects that overarching impact them, but really, how do we think about, we focus on the change management for your end user. So a lot of times we'll provide project, schedule sort of Gantt charts based on user. So here's what's happening in nursing. So instead of saying, here's the top 10 projects in IS, I say, here's what's happening to nursing in the next year. Here's what's happening in finance. And we include their operational projects. Because that also then helps us say, listen, we can't go live with these 3 systems over the next 6 months when you're also doing these other projects, right? Because your nursing staff can't take all that change. Let's think about moving things around. So it doesn't become about my capacity or like what my team can do. We try to not talk about that level of detail if we can avoid it. I mean, sometimes it just is, listen, I don't have anyone. Is there budget to bring in a temp? I mean, those questions happen. But a lot of times it's really trying to present the demand in their context, not your context. And that will help them, really better understand what the challenges might be and sort of what the right roadmap is. Like, let's create you a roadmap to get where you're trying to go. Don't give me one demand at a time. Tell me everything you're trying to get done. And so our, sort of leads in the various areas spend a lot of time out with their business counterparts or clinical counterparts. We attend their meetings. We want to be embedded as much in the clinical and operational teams as possible, because people talk about technology all day long without knowing they're talking about technology. So it allows us to also find problems that they may not have articulated yet, sort of try and resolve questions or issues sort of at the point it's being brought up versus sort of waiting for demand to hit us. So that approach of sort of embedding ourselves in the organization and really focusing on their ability, their capacity, the change management for their end user, I think is what works at my organization. It may not work everywhere, but for us, that has worked out, instead of sort of saying, here's my top 10 IT projects for the year. That approach hasn't worked in my organization. And so we have pivoted, when I've been there 23 years. So when I became CIO in 2017, I sort of knew what worked and didn't work, and was able to sort of pivot to this more, let's focus on you and not focus on us, approach, which has worked, relatively well to date. But it's a sort of another way of looking at it.
All right, very good. Thank you, Naomi. Rich, your thoughts?
I love what Naomi said about putting together Gantt charts and timelines, showing individual areas what their requests look like and how they can be plotted out. Because much as everybody wants everything yesterday, like you said, Naomi, in point of fact, the organization and the department really can't handle that kind of upheaval that would happen. Um, I also, by virtue of doing something like that, I also find that it would reinforce the notion that not everything is an IT project. Relatively few things are an IT project. IT is a catalyst and a facilitator to almost all projects within the organization, because really virtually everything involves technology. I mean, exceptions would be cybersecurity and plumbing behind the scenes and redundancy and that sort of thing. But by and large, by working closely with everybody and letting them know that we're your trusted partner here, we can help you time this out. We can help you mitigate whatever trauma your team members are going to be going through as you throw a lot at them is really important. I also find when you sort of raise the how do you say not now to folks who, when they're very passionate about a project, I think it's important to always start from the premise of yes, we'd like to do that for you. You have to yes, you have to say that, but you have to talk that talk and walk that walk. So you have to demonstrate through close collaboration over a long time that you're always there for them and that you will go the extra yard for them and you'll work with them. So when something comes along that you either can't do, period, maybe there's a cybersecurity component to it that makes it prohibitive, or it could be any of a number of things, or some that have to be deferred, they're willing to recognize that a little bit more, and it doesn't dent your credibility, because I never want IT to be the department of no. I mean, that's always a worry. I want us to be the department of yes, but under certain circumstances, we have to qualify what that yes is. And really working closely with all of your stakeholders, not being an island unto yourself, allows you to be able to credibly do that. So staying close to your stakeholders, working with them, understanding their worlds as intimately as you can, and helping them prioritize what in fact it is that they need is really a huge role for IT, I think.
All right, very good. Let me go back to Naomi, and then we'll go around the horn on this question. Naomi, you mentioned the idea of being sort of department or unit specific with their IT requests, and sort of laying out, for example, to nursing, hey, here's what's on your list, and here's where you are, and you doing that because it helps with change management, and they can understand, they can see that they're asking to change too much at once, and they can't handle it. Like, you guys can't handle this amount of change management, so it gives them that view. But what I want to ask you is that I understand that that's one dynamic, but isn't there also the dynamic of, as you mentioned, the IT capacity management here, and that has to be taken into account? What I was thinking of is certain skill sets that may be very specialized that could be needed for different projects, and I don't have a good enough grasp to say what those are. Maybe it's some sort of cloud skill set, or it's some obscure development where you have one or two people that are good at it, and they're tapped out. So even though as an IT department we have a larger capacity for what you're asking, I've got two people and they're tied up. So even though we want to sort of present things in terms of a department level, there is also the element that comes back to IT. So you do have both those trains, right, that have to run at the same time to get things done. Tell me your thoughts there.
Sure. Yeah, no, definitely. You do, for sure. I just, we try not to start there,
Right.
but there does come a point where, and, you do have some core teams, whether it's your, desktop build team, or maybe it's your integration team. There are definitely teams at your organization that, or within the IT organization, that cross the gamut, and they are the ones getting demand requests from all these areas as well. And so we do have some capacity or resource management tools within the IT department. We do actually capture, time reporting against various projects, as well as support, so that we can have a sense of, how busy is a team, how, is someone sort of over, allocated. So we have like this resource allocation tool. So we do use tools. So we have data, which is also helpful, that we can use, because that lets us answer when. When would this person be available? So if there is that sort of, the interface team in my area is probably the biggest one, where we have that sense of they can only work on so many interfaces at once. And so when would they become available? And so we can at least show the data. We also have, because we've done this time reporting for, probably 15 years now, we can actually say that type of project takes X thousands of hours or X hundreds of hours to do. Because the other challenge we find with demand is people want something and then they think it should take 2 months when it takes 6, right? And so we're able to at least show, having that data, having some metrics, being able to sort of show that you've done this before and this is kind of how long it took last time, also, gives you like a leg to stand on. It's not a, in my 23 years of experience, this is the estimate. It's, here's our data. We can actually show you this. We need these 3 resources to execute on this type of project. And, here's when they would be available. Here's when we can fit them in. If we obviously need to move something. So when, Mohammed mentioned regulatory, or maybe there's patient safety, there are times too you have to adjust a timeline and say to someone who already thought they were starting January 1st that we're starting you now March 1st, right? So that's never fun, but usually it is for a good reason. Here's this important regulation that just came down, or, where you have a vendor who's decided to, decommission a module and we now have to respond to it. So there may be times where you have to make those kinds of tough calls and deliver those messages. But I think if you have data about your department and you have structure that you can rely on when you do have to turn sort of the, turn the focus inward, and people are sort of like, I don't understand. The vendor told us it should be 8 weeks. So vendors out there, stop giving timelines to operational people, because you're just making the IT people mad. The vendor said it's quick and easy, and so we should be done and be going live within X number of weeks. We do have to sometimes rely on that internal data that we're using to say, listen, we've done this before. And it actually takes this amount of time. It's this many hours for these types of people, and here's when they would be available.
Excellent. Mohammed?
Yeah, I think Naomi touched on identical to what we are doing in our organization as well. I think we all know the capacity management in healthcare, right, isn't the managing the factory floor, right? You just cannot count available working hours, right? Everybody bring in different skill sets to deliver the value, especially if you have an Epic electronic medical record. Those are all people are certified on a different modules. I mean, I have close to 27 plus modules. I'm sure Naomi probably have a little bit bigger. Obviously, her organization is much bigger than ours. So we actually track capacity across multiple dimension, right? Based on the skills, who is available, holidays, PTOs are coming there as well, and match that capacity with the demand coming in, and share that capacity on a monthly basis to our stakeholders in our IT value matrix meeting that we meeting every month. So we categorize our work into the planned projects, unplanned support requests, routine maintenance, professional development, right? This helps us understand how capacity get consumed and identify optimization opportunities. So the data is the goal, as Naomi alluded to your example. So for example, we discovered that unplanned support requests, sometimes consume 40+% of your capacity. And that really derail, if you are using agile methodology, that's going to be derail your sprints, and your burned out chart going to be go down like a hell. So it's a very, very critical to have access to the data. And obviously we use a service now for our project management module that really help us track the resource commitment within our module. Each incident or maintenance request have a time tracking there as well, so we know exactly how much time we're spending on each activity and a task that we assign there, and that we are very transparent. I think Rich talk about that transparency is a key in our business, to be honest with you. If you put the data out there to stakeholders, they generally buy into it. What exactly you're sharing with them as well. And the other thing is in a demand, other thing I say, I think if you remember the old days, whoever is the most loudest, whoever has a lot more influential in an organization, they can get things done much quicker. I think things have changed now because once we implemented a proper scoring mechanism in organization, no one can challenge why are you doing XYZ project before my project. So that works out very well. So having a solid framework in place, I think is a very, very crucial today.
That's brilliant. I'm writing down some great stuff here. Rich, let me get your thoughts.
And as a smaller organization, I don't get honestly, I don't get as much pushback. Well, you said this will be 6 months, and the vendor said it'll be 2 months. I mean, I get a little of that, but because we are a small organization and we all talk to each other all the time and we're in frequent meetings with each other, I can just talk anecdotally as much as anything else about, well, this is how long it typically takes. If you want more detail, I will get you more detail. So I don't have as much in the way of formal tracking, but I have the history and I have a huge repository of notes and project plans and whatnot that I could always call on should I need it. But it's by and large, people, yeah, I think it's important that you were, and I said this earlier too, that CIOs remain very close partners with the stakeholders they're dealing with and earn their trust. And when the CIO says something, it's more likely to be received in a constructive manner if it's not they want to hear. And the CIO has to be able to have the wherewithal to be able to back it up and say, well, this is what happened. But oftentimes, if someone says we're not going to be able to start this project until October, and they say, well, I need it now, in one of our leadership meetings, that could be a discussion point that gets brought up and says, if we need to move things around, we can do that, but here's what the downstream impact is going to be. And I think we've been fairly successful in doing that on a relatively informal level because we're small. I think that could work for small hospitals. I don't know. I've been in larger hospitals. I'm not sure that scales up as effectively in a much larger system, but in our world, we can do that. And I think just building the trust and being able to document what you say should it be asked, and just we're all we're all kind of in this together, and I think people understand that.
Can I just add one more
Please.
thing? I mean, obviously, this is Naomi and Rich touch upon this as well. I think we also learn adaptability in our framework as well, right? The COVID taught us the prioritization framework must flex, right? Where the circumstances are different, right? I'll give you an example. Telehealth went from nice to have to mission critical for all of us overnight, right? So we need to make sure that we able to switch around the framework as well. I think that is very critical. Or you should have an escalation path in your framework, right? How you able to bend the rule and what circumstances and build the use cases around there, right? I mean, in my view, the frameworks only works, right, if it connected to something very bigger in organization, right? Make sure it connects to your enterprise-wide goals. That's where alignment become very, very critical among the leadership.
Excellent, excellent. I just want to just share some thoughts, and then we'll get to a few other things. So we've identified some real, some common challenges. We've identified some good ways to approach these challenges. What's fascinating to me is sort of the real pain points that are difficult. Naomi mentioned, um, her interface team being a high demand spot, and I don't want to describe them as a bottleneck, but I think of those pain points, and I'm sure they're doing everything they can. But you say, all right, where do we have our problems? Like, where is the acute demand? And there it is, right? For you, that's a spot that can hold things up. Um, and then Mohammed mentioned the idea of PTO and holidays. Like, it's okay. So we have this acute point of demand, and it's got to function 100% all the time, but it can't because they're human beings and they have to go on vacation and they get sick and things get delayed. And then you mentioned, other things that can come up, like there could be a change in the compliance requirements where they have to address something. There could be the vendor does something where they have to address something. These are the fire drills where they get put off. Um, and so that's all fascinating to me. And that's probably where you have to spend your thought and your time, is to manage the acute points of demand and make sure they're really humming. So again, totally fascinating. It's a challenge, and we've identified lots of ways to go about it. Let's get one question from our audience, our good friend, talk about industry legend, Bill Spooner. Uh, been around a little while, Bill. Thanks for joining in today. Bill would like to know. He says it would be interesting to hear how effective each panelist views its governance process and how it is impacting its workload. I'm not sure anyone's going to throw their governance process under the bus, but maybe however you want to describe it, weigh on it, give your thoughts of maybe what works well, maybe what can be improved. Rich, hearkening back to a few months ago, but when you were still active, thoughts on governance?
Governance is critical because everyone has to, if they don't totally buy into what's being prioritized, they have to know what it is and why, if nothing else. And it has to be transparent as well. So I mean, everything needs to be out on the table. We said as a smaller house, we don't have as much formal structure around that, but we certainly do have structure and we certainly do have accountability that if we're supposed to knock off X, Y, and Z by such and such a time, and we don't, we need to explain that. If something does go off the rails that we can't anticipate, we have to come back and be able to provide an alternate path to getting there to the extent that we possibly can. So governance is critical. Governance can't be so crushing in terms of the administrative aspects of it that things don't get done. You need to be able to be both comprehensive and also be nimble. Sometimes when there are many, many different layers of governance that 10 different people need to sign off on this, and this box needs to be checked, and this needs to be checked here, and this person needs to weigh in. Sometimes you could wind up having a paralysis by analysis situation. So you want to be able to have the kind of accountability that governance brings to bear. You want to make sure all the right voices are being heard and the voices that are in the highest position to prioritize the right things are being able to do that with a full complement of information. But you also want to be nimble when something comes along that we need to sort of throw the cards in the air and start anew. So governance is important, but it shouldn't be crushing. And that would be my few words on it.
Very good, Naomi.
Yeah, I would say governance also needs to, as I sort of said in the beginning, reflect the culture of your organization. I think that's really, I don't have something called the IT governance committee on purpose. That wouldn't sort of work within my organization. We do a lot of governance related to budget, right? So the capital budget process is really where a lot of the sort of what's going to be funded is what gets done, right? So if you aren't going through a process to get something funded with us when we bring forward all the IT capital needs, it's where's the money coming from to pay for the thing that you're looking for. And so, yes, I have some discretionary and we have a way of sort of doing things, but like budget is one big way that things get sort of prioritized because that means there's, institutional support for this item because we were able to get the funding we need to do the major project. So for us, governance is probably a little less structured than what all the books will tell you to do. So but it's what works at the Dana-Farber. I will say the sort of hearkening a little bit back to the last question though too. One of the big challenges and things that we've been working on is how do you make sure that what gets approved from a capital perspective
Mm-hmm.
means you then get the operating support that you need later, right? That your budget, your operating budget went up because you're paying for more licenses or you have new maintenance fees, or to your earlier point, we might need resources to execute on this capital item. And are you going to operationalize those resources so we have them long term? So for me, the governance, and it goes like beyond the demand of when can you do this project, it's, well, what's the capital budget? Is there a cost to us, whether it's resources or new software or something, or bringing in contractors? But then what's the operating, downstream cost? And so when we're trying to get work done, we try to display all of that. So
Mhm.
it isn't just, hey, let's approve this thing that everyone thinks is great. Let's like understand the total impact of that piece of software or change, to software that will impact the whole organization.
And you touched on that earlier, Naomi, and that's a huge point. And that came up in a discussion I had recently regarding working with vendors and startups and things like that. Um, the cost of the pilot. Now, for example,
Yeah.
somebody used the example that my first time around, sort of my first rodeo, I didn't budget in the cost of a pilot, and I had to go back to the board and ask for that money, and that was really not a good move. They don't like that.
Yeah.
But if next time around you understand that the people requesting it, the users, they have no idea. As you said, you've got a much bigger picture of cost here, not only initial but ongoing. So when they ask for something, the number that they may have been given by the vendor could be completely different than the number in your mind. And also, you're thinking of, and I think I had this image in my head when you mentioned this before of sort of a horse as the IT department that keeps getting things put on it. And the person that put the thing on it walked away, doesn't realize that the horse is going to have to carry that thing now forever. So it's just this constant addition. And you see that, but the users don't see it. So it's just a really interesting point. Mm.
Well, I'll have to share, our one of our clinical leaders said to me once, I sort of think of your job as that guy who like pushes the rock up the hill, and
The
when it gets to the
Sisyphus.
top
Yeah.
it falls back down. And
Yeah.
I thought, wow, I'm not sure that's how I want to think about my work, but it's not necessarily incorrect.
That's great. That's great. Mohammed, anything there? Any thoughts?
Yeah, absolutely. I think the Bill, this is a great question. I think in today's time, we are IT being asked to do more for a lot less, to be honest with you. So I would say our governance process is very effective, but it's kind of like going through the airport security. You don't love the extra steps, right? But it's keep everyone safe. For us, it's a big decision, right? Aren't made in the IT small room, right? We really want to bring our clinician on a table and operations, and this would be joint decision making. So I think it's very, very critical. Other question that Bill has there, does it really add a workload? Absolutely. There are more check-ins, right, and reviews, but the upside is time well spent on these activities sometime, and then also protecting an IT values there as well. No one will be come and challenge you down the road. Why did you implement XYZ without going through the process? So you have an answer for that as well. So governance is so critical, especially nowadays.
Yeah, I want to probably use the rest of our time. I'm probably not going to do the ask a co-panelist, although I would love to. Do you guys have, does anybody really want to ask their co-panelist a question? Otherwise, I'll go with something else. No, everyone's good. Okay, so let's go a little deeper on governance. What I've always been curious about when it comes to governance is who owns governance. Now, for example, we talk about governance as a thing. It's a picture an org chart type thing, a committee. This is the committee for whatever, and we have people on that committee from different constituencies that we think will help us make a good decision in this area. Somebody put that together, right? And somebody could have made a mistake. Somebody could have someone on there that doesn't really need to be there. somebody could have left somebody off who needs to be there. I mean, there could be, you could get into the weeds here on personality issues. Like, oh my God, you got Dr. So and so, forget it. We're never going to end a meeting. Who knows? But my point is, who owns governance from on high? And this might be different for each committee. Who put the committee together, and who is in a position, theoretically the same individual, for making adjustments, for saying, you know what, we did forget someone. We need to have so and so on. Or, you know what, Dr. So and so really doesn't need to be here. It's got to be living and breathing. We can't assume it's perfect. And I've always been curious as to who owns a committee and who has the power to make adjustments to these kind of things. So let's go around the horn. Mohammed, let's start with you.
Yeah, that's a great question, Tony. So I think let me give you an example for us in our case. Our EHR governance, which I say probably be 80% of our work around that epic space, is chaired by clinicians. So it's chaired by multiple providers who are the chairman. They have ultimate decision making. So our CMO and a CNO chair that committee. I'm not even member of this committee as a CIO. Actually, my team goes in there because I don't want to influence any of the decision making there as well. We are also putting together, and it's not live yet, putting together a governance around the ERP because we are going through the Workday implementation now. We don't really have that live yet, but we are going to implementing something very similar. We are CFO and COO going to lead that committee there as well. So I think it's a very, very critical. You know what? I always tell this to my wife as well, right? If you wanted to control the budget, let your wife run that budget is always better because you're always a big spender. So that's exactly what we do. We're putting a decision making in hands of the provider where the request is coming from and let them make a decision on do we really need to do this now? And why do we need it? I think the question that I asked my team and my stakeholder is the change that you're requesting, why it's not about can you build this. The question is, does it really make a difference in a patient's life? Does it really make a difference in our provider's life? Does it going to reduce the friction for our nursing team? They go from room to room and room to room every single day. If the answers are none of the above, that should not be new request to me. We should park that for time being.
Very good. Naomi, thoughts around this governance structure and making adjustments to committees and things like
Sure.
that?
Yeah, and we're actually also in the midst of ERP. So, Mohammed, you and I can talk offline about
Yeah,
that. It's
yeah,
never dull.
yeah.
But so I would say my department does sort of maybe support create the committees. We, try to sort of assume or identify who the chair or sort of leads of the committee would be that are going to be business, operational, clinical people. So in, our ERP world, we have sort of a lead for, 3 or 4 different areas. And that's, those are the business leaders that are making decisions. But my team is like the administration of committees does come from my team in the sense of, we're getting the agendas done, we're getting the team site set up, we're keeping track of things, we're managing budgets, but the decision making is happening, whether it's our clinical leadership. So in our Epic world, we have, a physician, a nurse, a pharmacy, our chief pharmacy officer, folks that all attend a meeting and, they really are the decision makers, but we are sort of staffing these committees to sort of make sure they happen and to tie it back to things like budget and those types of things where they're just able to, think and decide, and we sort of do the work to get us there and beyond.
All right, very good. We're gonna just get a final round of final advice, thoughts from our panelists, and then I'm gonna let everyone go. So, Rich, let's start with you. Your final best piece of advice in your vast experience for managing expectations among users. When you have experienced sort of frustration from users, um, how have you handled that? Do you sometimes do the one-on-one meeting and just, what are your thoughts there?
I say from the outset, build trust early on. Don't be the department of no, be the department of yes, but qualify it as needed. And if we are somehow having a divergence between what a particular department's expectations are and what we're able to deliver, be transparent about it. Be transparent as to why. Give examples as to why those expectations may not be doable. And again, reinforce that, through all sorts of actions that we are your partner and we want to do everything we possibly can to accommodate this, but we can't, and here's why. Again, that works if you've been able to establish a foundation of trust early on where they know that you're credible and they know what you're saying carries weight. If people think you're just looking to throw obstacles in the path, then they will view that differently. So it's very important to be seen as a strategic partner and as one who will go the extra mile to help you any way they can. So when something does come up, it's viewed differently, and you can work collaboratively to come to a good resolution.
Perfect. Yeah, Mohammed, I think really the underlying point of this whole discussion is IT departments do not want to be perceived as inefficient places that get a lot of money and don't produce a lot of results. So how do we avoid that?
Absolutely. I think here's what I learned after 27 plus years in the healthcare, right? Um, Technology is never a limiting factor, right? It's our ability to implement thoughtfully, support it reliably, and ensure it truly serves the people delivering the care, right? That's what capacity management is really all about, right? Healthcare capacity management in IT is very, very critical, as I said before. We are asking to do more for a lot less nowadays as well. Remember that capacity management is ultimate about enabling success, right? Not preventing the failure. Your goal isn't saying no to the request. As Rich said, it helps organizations say yes to the right things and no to the wrong thing. That's exactly the goal is. So my recommendation to the people who listening to this webinar, build relationship before you need them, right?
Mm,
And the trust and understand you develop during the building that relationship will be very, very essential when you face a crisis situation with those people.
that's great advice. Great advice. Naomi, your final thought.
Sure. I obviously agree wholeheartedly with Rich and Mohammed. And the maybe some advice I would say is, we talk about this as CIOs. All of your staff have to do this. Your staff, your analysts need to be in the departments. They need to be building relationships with the users of their systems. They need to understand healthcare and how it works. And so, to Rich's point, we can help them achieve their goal, or and to Muhammad's point, show them how the thing they think will help them won't,
Mhm.
because we need to understand their workflows and how they take care of patients, or how they do finance, whatever it is that they do. We need to understand their workflow and then understand how technology will make that better, faster, different for them and achieve their goals. So the days of sort of sitting in an IT department and being behind a screen and answering the phone and, sort of saying, well, the system can do A or B, you pick. For me, they're long gone. You have to be embedded in their world so that you're a trusted partner from the analyst all the way to the CIO. And that focus on them and their needs builds that trust so much more quickly than just meeting monthly or some other cadence, right? So really becoming partners at all levels, I think will set you up for success.
That's fantastic. Fantastic. That's about all we had time for today. Regarding continuing education, check out the final slide in this deck. You'll get an email when the on-demand recording is ready for viewing. If you want to sponsor an event with us, you can reach out to Nancy Wilcox from our team, and you go to our website to register for upcoming panels. With that, I want to thank our tremendous panel, Naomi Lenane, Mohammed Siddiqui, and Rich Temple, and I want to thank you for attending. And with that, everybody have a wonderful day. Thank
Thank
you.
you.
Thank you,
Thank you.
everybody. It's a
Thank you,
pleasure.
everyone. Pleasure.